And your direct, like Vignesh Dental Hospital is also in Chennai.
Yeah, it's in Chennai.
Yeah. So good afternoon, everyone. I hope you all are doing well. Welcome to this brand new episode of Dent-e-ssentials, where we put up trending topics of dentistry and beyond with experts from the dental field. So common problems that a dentist deals with are sore or loose teeth, orofacial pain, temporomandibular joint problems, and wear and tear of jaw structures. The principles underlying occlusion lie at the core of restoring functions and aesthetics in the oral cavity. Even when it comes to designing a smile, the principles of occlusion apply. So hence, it is of paramount importance for a dentist to know all about occlusion. So here we are with our expert today at this exclusive dental essential session with Dr. B. Mohan, who will be talking about occlusion, the gateway for success in day-to-day dentistry. Welcome, Dr. Mohan. Introducing our speaker for today, Dr. B. Mohan is an MDS, Conservative Dentistry, and currently the director of Vignesh Dental Hospital in India, visiting professor of MAHSA University in Malaysia as well. Dr. Mohan is a renowned dentist specializing in conservative dentistry. He's won the Best Cosmetic Dentist by Lifestyle Awards in India in 2016. Another one is Superstar Award by FamDent India in 2018 and EVY Award by Cosmetic Dentistry for outstanding service in the field of cosmetic dentistry in 2020. He also has several national and international publications to his credit. So it is an absolute pleasure to have you with us here. I would request you to begin your session. If you could share your screen.
Yeah.
Yeah.
A very good afternoon. Thank you, Dr. Shah, for the wonderful introduction. Very good afternoon to all the participants. I think it's a post-lunch session, and I hope to make sure that you don't sleep and it doesn't become a lullaby for you to sleep after the lunch. If those who are having lunch and watching, most welcome. I'll make it as interesting as possible for the next 35 to 40 minutes. Firstly, I would like to thank the Docplex for giving this nice opportunity to share a little about occlusion or the topic. They told me there are so many dentists around, make sure that it is useful to everybody. So that's why I chose the topic, and they told it's good. We can talk about this because it's going to be used for day-to-day practice. So I would really slowly coming out of this pandemic. Hopefully, we touch normal very soon. Once we talk about occlusion, everybody runs away. That's a serious fact, actually. happy. We think that's occlusion. That's not at all occlusion. There is something much more in occlusion than what we actually pursue. So I would really thank these two great individuals before I actually go into and talk to you what is the importance of occlusion and how it plays a major role in day-to-day dentistry. Peter Dawson, in his textbook, is clearly made that the goal of any treatment, for that matter, not only aesthetics, is to develop a stable stomatognatic system. If somebody is looking at to buy something, he's Peter Dawson. And if somebody is looking to buy a textbook, this is a Bible for us. Actually, his textbook is a Bible for us. A very nice gentleman. Until his last date, he was teaching. That is what is more important. Anybody wanting to pursue more on this, Dawson Academy is always welcome to you. And then it's functional occlusion from TMJ to smile design. He was one of the best selling textbooks in dentistry, followed by Carl Misch implants. So if you want to buy something today after this lecture, please close your eyes and go to Amazon and buy this book. It's not at all expensive. Unfortunately, we lost him in the year 2019, but he's a legend. His legacy stays back. His textbook speaks volumes about himself, and these concepts will never die. The next to him is another god for me is Dr. John Coy, Seattle, Washington. Amazing gentleman and a human being. Both of them are just amazing. In fact, there are a lot of people there. I personally underwent training in these two great people, and that's why I'm here right in front of you. So he's a legend again. His center in Seattle, anybody willing to go there to get trained, that's more than welcome. That will definitely change. So at the end of the day, none of us want failures, right? We don't want to do dentistry and see failures. I don't want to do a restoration. I don't want to have my patient sitting in my reception the next day with a broken restoration. I don't want that. Does anyone on the audience need that? No, we don't want that at all. So we want to avoid failures. How will you do that? Is only when you understand what causes failure. So in this textbook, again, Peter Dawson has clearly told that 90% of the failures are the direct result of failing to plan. Most of us fail to plan. I'll tell you why. The system is like that. The minute we put the mouth mirror into the patient's mouth, we not only find the clinical findings, we also start thinking about the treatment plan. So I look into it, okay, DC46, I will do root canal, why do we think like that? We do examination first, then we collect all the data, sit down, gather, and then do the treatment planning. Unfortunately, that doesn't break. Until and that doesn't break, our treatment planning doesn't fall in place. So please, I don't know what I'm going to do in this 40 minutes or 35 minutes, but if I'm able to motivate you guys listening to me to completely view at a different perspective of the treatment planning, I'm happy. That is one crux. What I want to tell you is that if you could properly plan your treatment, then 90% of your failures can be avoided. Another thing is that the minute I talk about occlusion, what people generally think is that, oh my God, it's full mouth rehabilitation. Oh my God, full mouth rehabilitation is a bigger version of occlusion, wherein all concepts of occlusion come into play. But what I'm trying to tell you is that everyday dentistry, every patient of us will need this. Haven't we seen all this in our day-to-day practice? I wish I could see all of you and ask each one of you seeing this picture. Everybody will raise your eyebrow. It's a day-to-day affair in your practice. Don't you all see this? And not necessarily it's related to the complete 28 set of teeth. It can be with one tooth, it can be with one segment, it can be with anything. Are we going to shy away with this, or are we going to try and attend to this? Because we all know this is a complicated process and we always tend to shy away. But who is going to treat them? What are we going to do? Just do a restorative work and see that restoration fracture? Because if enamel could not withstand those complex forces acting on the restoration, is our restorative metal going to withstand? How are we going to solve these day-to-day dentistry cases? One aspect is attending failures. The other is attending these. Not always full mouth rehabilitation is when you look at occlusion. I actually, when in our courses, we tell that if somebody is going to get trained and put a TMJ disorder center, you will not have time to relax. Mark my words. Today, so many cases in our practice, so many cases, people, they introduce me as a cosmetic dentist, but that is very relatively small portion for me. For me, whole work revolves around restorative dentistry, treating people with TMJ. If I'm fully into it, I will not have time. So dentistry, there are so many possibilities wherein you can sit down and work. Today there are increase in number of cases only because of change in lifestyle. and the dietary habits. This is enormously caused not only an issue of plethora of medical problems, but also a lot of dental problems. Stress has become a common term today, right from kindergarten to an old age. Every problem is related and multiplied due to that stress. TMJs, that so many patients dropping with TMJ. So if you're well trained in this and if you're able to handle this, then mark my words, I can give it in writing today, you will be super busy, super busy. You will not have time to relax at all. And that's what we call today as occlusal disease, as Dr. Shah beautifully put it in introduction. It is the number one cause of all these factors listed in this slide. We see them daily. Tooth loss, patient knowing, doctor, something is aching, I'm not sure what's happening. Orofacial pain, undiagnosed problems, so many things revolve around this, and the only answer is occlusal disease. We need to open up our eyes and see this disease and consider this as a disease, first of all, to make sure that we are able to treat. So first our eyes has to open up, our brain has to know, and then we realize what is happening, and then we start treatment planning and treating them. So before doing all that, I just have two key questions to you. Do you really love dentistry? That's very important. If we do not love our profession, we will not be able to passionately treat our patients. At the end of the day, we are looking at that quality dental care. So we need to love dentistry and visualize your role as a professional. It's not that cut and fill, cut and restore. No, that is not dentistry. It is moved something. Actually, when Dr. Shah asked me, do you want to do on current trending topics? Of course, I thought I'll do digital or something fancy. But at the end of the day, there are so many participants. She told me it should be useful to everybody. I don't want something to be useful to only a group of dentists who are going to practice what I'm going to talk, but I want this to be useful to every dentist practicing. That's why I thought this is very important. People high time start realizing what is the importance of occlusion. How do you visualize yourself as a professional? It's not, dentistry is not all that easy. It's so very complicated to us, especially when it comes to occlusion. That is the ground basis for every dentistry what we're doing. Unfortunately, that has taken a backseat because of the complication of the subject. Not at all complicated. Tell me, haven't you seen this in your practice? Yes, half of my time is spent on retreatment. 50% of my cases are retreatment. So where are we? Where are we? Where is success? Where is failure? Just sit back and think. Somebody's done a silver amalgam. Somebody wanted to patch it up. It's not staying. It's not about silver amalgam. It's not about composite. It's not about GAC. We have not understood the problem. We have not understood the failure. That is the issue. I'll show you some cases. It's very, very interesting. Look at that. Failure. We all want to avoid failures. And half of my time, as I told you, it's only solving failures, right? Now, I'll show you a simple case, how this works. Like I told you, occlusion and occlusion principles are not 28 teeth treated together. Even when we talk about, imagine this was a full mouth rehabilitation lecture, even 2 teeth can become full mouth rehabilitation. People don't understand that. People feel that full mouth rehabilitation means 28 root canal, 28 crowns. That is absurd. I can treat a segment. I can treat a couple of teeth. I don't even treat. That's full mouth. So many times it ends with reshaping. Restoring is finally the last part. I can just do some occlusal equilibration. The case is not done. That is full mouth rehabilitation for me. I need to do a functional articulation. I need to check what's happening, where exactly the problem lying. The patient is done with that. So many of my cases are just done with occlusal equilibration. Do you mean that I don't charge my patients, or do you mean that I've not done any restorative work? I've done the best possible minimal invasive dentistry for the patient, still rectifying the problem what the patient wants. So please, first myth, erase it from your heart that occlusion is for full mouth rehabilitation case, in other ways, nothing. Now look at this case. What is beautiful about this case? This patient comes to me and tells me that, doc, yeah, I can see that. She doesn't have to tell that. It's broken. Yeah, tell me what happened. Doc, it's just 2 months and it's broken. The dentist told me it's the best of the best material, and then you get beautiful aesthetics, beautiful strength. I paid so much, but it's broken. Zirconia crowns. Okay, doc. So why you didn't go back to him? No, I'm not very comfortable. I found you in Google and I've traveled all the way. So I want this to be solved. So what is my issue? Just to change the crown or to figure out what's happening? My problem is to find out why the failure happened. It's not just to do some core build up there or post and core and then do 2 crowns. That is not my job. Again, my crown is going to break another couple of months. I've not solved the patient's problem. The patient's problem are not the crowns. The patient's problem is the failure of the crowns. So here you have to strike a balance. Of course, aesthetically also it's not pleasing for me, but the patient is not bothered about that. For me, it is not how beautiful I do the work. It's how long it's going to last. That's called clinical longevity. So how do I establish that? So I need to figure out what is happening in the patient's mouth. So we thought that we will do the scans for the patient and we will virtually articulate. Today it's all digital dentistry. So we virtually articulated and then we found out the issue. The issue was with the anterior guidance. So this is how we actually digitally communicate with my laboratory today. In fact, I can also do it, but I thought my laboratory is going to fabricate the final crowns. I'm not going to do the final crowns because a little bit of artistic work involved. So I thought, let him do it. Then he found that, doc, there is an issue with an anterior guidance. So how do we solve the problem? Is there a clearance issue? No, this is not a deep bite case wherein you have a clearance issue. There is an anterior guidance issue. I'm going to explain to you what exactly it's about. So how do we solve the problem? Look at these 2 crowns. What is digitally designed? It's slightly labially placed. Oh my God. If you could labily place it, the anterior guidance problem is solved and then the crown is not going to break. But if I'm going to place it labially, the patient is definitely going to give me Bugs Bunny teeth. The problem most often why it happens is that we don't allow the patients to see what we are seeing. The minute the patient next time comes, I'm going to put on the screen and tell her, look, this is the problem. This is what is going to happen. And the solution is to place these 2 crowns little labially. But where do we strike a balance? So I give a prototype restorations for the patient. I mill it with PMMA. We'll put it in the mouth. We'll see how it is. Obviously, she told it is little bulky. Why that bulk is necessary is I need to layer the ceramic restoration. Only then I get little aesthetics, not compromising on the function. So it's a balance between aesthetics and function. So the more I reduce my labial surface, the less room I have for any aesthetic work. So we struck a balance somewhere that I reduced a little bit of the labial bulk and then the crown was there in the mouth for 3 months. The PMMA crown was there in the mouth for 3 months without even any complaint. She was happy. At that stage, I told the laboratory, we will copy this and do the crowns, but only thing is that we don't have an option. We cannot layer. We'll try to do the maximum aesthetics possible because the restoration is in the aesthetic zone, at the same time not compromising on the function, which is going to play a vital role in the longevity of the restoration. So this is the final restoration. It's now 8 months. So please, my dear viewers, it is not to do with 28 teeth. Every single tooth, every single patient we see, the occlusal concepts are so very, very important. Occlusion plays such a dominant role in everything. As a dentist, it is our responsibility to understand so that we don't cause any major waste of time, not only for us, but also for the patient, and ultimately give patient satisfaction. So please understand that it plays a dominant role in a day-to-day dentistry. Every patient requires it. So I'm going to give you just 5 key determinants of occlusion. I'm going to confuse you with so many things. Just 5 things for you to understand so that you know this is all about occlusion. Fine. So 5 key determinants of occlusion. There are plenty, 10 if you ask me. I've just condensed it into 5 so that it's easy for you to understand and put that into practice. Now, centric relation. I am not the first person to introduce this terminology to you. N number of times you've heard about the centric relation. What is centric relation? Centric relation is the peaceful position of the condyle to rest in the base of the skull. So where it beautifully sits back in the skull is centric relation. Okay, it's when the mandible properly gets aligned to the glenoid fossa. Okay, what is this all about? So when we were all born, we did not have teeth. So teeth and joint doesn't have any connection. There's a fixed relationship. That's all. There is maxillary teeth and the glenoid fossa. That's all. And now we have mandible and the condyle. So there is a fixed relationship. So condyle has to orient to the glenoid fossa. And for us, the occlusion is this one. This is occlusion. This is not occlusion at all. The relationship of the maxilla and the mandible in the most peaceful position is centric relation. Fine. So it is very difficult without understanding the TMJ, you go into it. So Teeth and joints are a part of functional unit. It's not separate. So the joints and the teeth have to correlate together. So this joint position is called centric relation. That's all. Do not confuse teeth and joint together. They functionally come together, but the joint position is always the centric relation. So centric relation is a joint based position found independently of the teeth. It is a bone-based reproducible position. What do I mean by this is that even if you don't have teeth, we have centric relation. Yes, we were all born without teeth, but with centric relation. Some people lose the teeth, but still have the centric relation. So teeth is out. It is joint. Reproducible means 100 times you take the centric for me, 100 times it's the same thing. It's not going to vary from here to there. So this is the beauty of centric relation. So now what comes to you? Centric occlusion. There is nothing called as centric occlusion today. It is called as maximum intercuspation. Maximum intercuspation is a position where your upper and lower occlude. It's based on teeth. So this is my maximum intercuspation. This may or may not coincide with my joint. That is where the problem comes. So what happens when it does not coincide? When I try to bite, but my joints are not going into place. So that is where all the problem starts. Attrition starts only because of that. When there is a hit and slide concept, when the one of the tooth is supraoccluding and all the muscle starts to get fatigued. All the muscle starts to get fatigued. Then patient gets orofacial pain. So many things happen. Attrition happens. If the joint doesn't want that tooth to be there, it'll chop it off because the muscles are more powerful than anything. Like how much ever you have your bone strength, it's a muscle strength that allows you to carry the weight, right? So if your muscles building like a bodybuilder, it's a muscle that determines the ultimate position of the bone. So muscles play a huge role, and if the centric and the maximum intercuspation doesn't coincide, that is when this happens. So it may or may not coincide. Hit and slide concept. So it may coincide or it may not coincide. If it coincides, then probably you call it centric occlusion, but don't use the term centric occlusion. It's maximum intercuspation because you don't know where exactly the joint is till you take an MRI. So maybe the patient is comfortable there. That's all. So if the patient is not comfortable there, then so many TMJ issues start up there. Now, that was centric relation. That was maximum intercuspation. The third most vital thing is the anterior cadence. This is one of the reasons why, oh, I did a beautiful filling, I did a beautiful restorative work, a class for composite, a diastema closure, beautiful isolation, beautiful bonding. I followed all the protocols that was taught to me. But look at that, in 2 weeks, it's broken. Where did I go wrong? I did a beautiful aesthetic laminate, I did a beautiful crown, but it broke. It dislodged. It's only because of anterior guidance. What exactly is anterior guidance? Is that like we have our maxilla and the mandible, right? So when the mandible starts to move, it obviously comes like protrusive movement. So it is an eccentric occlusion that when the mandible starts to move, open your mouth, it'll never open like this. It'll just slide and then open, right? This is God's mechanism. Because if you open like that, it'll choke me. That's why God is created in a way that it'll slide and it'll open. When it slides and it open, your lower anterior comes in contact with the upper anteriors. At that time, none of your posterior should contact. If the posteriors contact at that point of time, anteriors will get off. So this is what is anterior guidance. When anteriors are in contact in the eccentric, the posteriors should never touch. What happens if the posterior touch? That's all. Whatever you do in the anteriors, gone. And all the patients coming with that lingual force are completely treated because loss of anterior guidance. So if you try to do some restorative work, they're going to go off in some days. So if you have a failure in anteriors, please make sure that your anterior guidance is perfect. Next commonly asked question for me is vertical dimension. I'll increase 3 millimeters for this patient. I'll increase 2 millimeters for we cannot tell that arbitrarily today. Actually, vertical dimension, we have one at rest, one at occlusion. Like you clench, this is at occlusion, and one like this with the leeway space in between 2 to 3 millimeters, that is at rest. So this is actually dependent on the masseter muscle. So the length of the masseter muscle is the determining factor for the vertical dimension. So generally, when there is a loss of tooth structure, the bone comes along with that. Generally, you never tend to see the patient's uh, vertical just collapsing like that until and unless the attrition pattern is so fast that it is not allowing the bone to compensate. Then only there is a complete vertical face dimension loss. Only then we think about doing it a little bit of increase in vertical. How do I do that? Is that I record the centric and articulate the model. The minute I do that, immediately the verticals will open up. Then I know how much to do it. So don't do it so arbitrarily. Okay, this patient, I will do 2 millimeters. This patient, I'll do 3 millimeters. You cannot do that at all, my dear friends. That is not the way it works. Anything revolves around the functional articulation of the problem, what you're seeing. The next last thing is a neutral zone. So we have the centric relation, we have the maximum intercuspation, anterior guidance, and then we have the vertical dimension, and now the neutral zone. The neutral zone is the most important thing that is the cause for relapse of orthodontics and orthognathic surgery. In the initial stages, okay, ortho, it's okay, relapse, you teeth, you move, but orthognathic surgery is they're putting screws inside the face and it's all moving out. So imagine how much is the muscle pressure. So there is a neutral zone. What is this neutral zone? Is that I have my facial muscles, I have my tongue muscles, right? Have you seen so many times your mouth mirror bends with the tongue force? Yes, all of us have seen that. Patient's tongue has small muscle giving so much pressure that you can't even hold your mouth mirror. So there is the zone between the tongue and the buccal muscles, ultimately the muzzle. So the buccal muscles are there, the tongue is there. That is a small space in between. That's where the teeth has to be. If you try to move the teeth or bring the teeth or like this, the buccal muscles of the tongue will not, like, they'll just push it away. So without deprogramming the muscles, if you try to do any too much of proclination or the orthognathic surgery, we are going to end up in relapse, or ultimately I will call that a failure. So according to me, or according to the textbook, there should not be any relapse in orthodontics, but we are violating the muscle force. That is when all these issues happen. So it is not only dentist means not only teeth, the bone, the architecture of the bone, the muscles, everything has to be understood. That's why they taught us the facial muscles and the anatomy and the physiology. Everything plays, because deprogramming, everything is so very important that if we do not understand at least these 5 key determinants, one form or the other form of failure will be in our hands. So in complete dentistry, what is that? Okay, if I'm telling cosmetic dentist, that doesn't mean I always create beautiful smiles. Yeah, that is true, but not in the compromise of the function. Got it? So get the mouth healthy. I cannot have a visible root canal failed tooth, or a root stump, a failing tooth, wisdom tooth, something, and then creating beautiful smile. It will not work at all. If the posteriors are not stable, nothing will work. I cannot have an active disease process in my mouth and create a beautiful smile. That is the stupidest thing somebody can do. When you have so much going on the posteriors, I cannot create an anterior smile. So get the mouth healthy, disease free. Number one, all active disease process has to be stopped either in the process of root canal therapy or extraction. Okay, done. All active soft perio, soft and hard tissue disease are put to stop. Only after that we start thinking what is going wrong where. All active disease process has to stop. I cannot have a cardiac patient with a heart attack to do a smile maker. Will I do that? Will not do that. I want him to have a good, stable, healthy life. Then only think about any of this. So first is to remove all active disease process, then get the TMJ stable and the occlusion stable. So I'll get my stability of my joints and the teeth in the posteriors. Only then create a beautiful smile or any restorative work. So please, this is a mantra. Get the mouth healthy, get the joints and the TMJ stable, then create a beautiful smile. So this is what is complete dentistry. So in the lecture, as I told you, I don't know what I'm going to teach, but if I taught you this is the crux of the summary of the whole thing, is that to change the way in which you treatment plan your patients will definitely give you predictable success. Because all of us today are looking only at predictable success. Predictable success is not this to me. This patient comes to me and tell, doc, that's been there for 15 years. Don't ever touch that. I want scaling to be done, but not on that side, because I'm very, very happy with that. After seeing this X-ray, I was just, oh my God, God only knows how that's staying. Sometimes I have a single crown and it still keeps coming off every 10th day, and this is there for 15 years. That is not predictable success. Predictable success, the minute you do, you should need successful. It's not the small warranty card do, because predictable success is much more than that. Now look at this. Predictable success. Here is a case wherein every single tooth in this arch is going to get treated with perio, with endodontics, and with the prosthetic components. And we completely rehabilitate the patient. Yes, it doesn't stop there. Predictable success is that I see this patient now, it's 2022, it's still there. Not a single restoration chipped, not a single restoration debonded. Nothing has happened to the patient's joint. She's happy, healthy eating after 10 years. This is predictable success, right? This is a patient. Everybody changes, right? If people can think that I can change something in the intraoral pictures and do it, but look at that. After the treatment in 2009, everybody ages, and there she's right in front of you in 2019. This is predictable success, and that's what we call responsible dentistry. Let's do responsible dentistry with predictable success. The foundation for predictable success in day-to-day dentistry is understanding occlusion, without which it is not possible. So, okay, that is fine. But what about the material? There are only two solid restorative materials to us. One is ceramics, the other is composite. So people ask me, when do I use ceramics? I always love ceramics. I always do composite. That's why I picked up a case for you guys. Each has its own properties. Composites, the modulus of elasticity is equal to dentine. Ceramic is equal to enamel. So they are two different materials and they have two different indications. The longevity of composite is obviously 6 years. The double is ceramics. So understand, in a simple equation, I put it like this. Now, this is what we call it as biomimetic dentistry. So you replace enamel with enamel-like material ceramics, dentine with dentine-like material composites. So don't get into the fact that, oh, I love composite, I love ceramic. Don't do that at all. Please don't do that at all. It is what the situation warrants. It's not what you want to do. What warrants for the patient is the material of choice. Do not get confused between these two materials. Whenever ceramics is required, you ended up with ceramics because you need to think like a biologist. Dentine and enamel are two different tissues. The most problem is we always consider technicians. Is that the role today? No, this is not dentistry at all. Today we are talking about minimal preps or no preps. Got it? So where is the question of the, in fact, before Corona, when I was lecturing, I always told that even 2 years before that, I was telling that a day will come that somebody will put air rotor handpiece into lock and key. I was very happy because we all are so much into it. The minute we put our air rotor handpiece in the patient mouth, only then we feel happy. That is not the fact. Today, it's without anything we can do, because please start thinking like a biologist. We are all dentists handling hard and soft tissues of the oral cavity. So let me wind up with this one small case wherein to explain to you what exactly is occlusion, role of occlusion, and what are the restorative options that can come into play. Now, it's obvious, I don't have to tell you that something is happening in the anterior segment, but the patient is happy, nothing to do with anything, but the lower anteriors are worn out and the lower posteriors are worn out. Uppers are fairly good. So I'm not going to touch the uppers, they are all fairly good, but the lower posteriors have completely damaged and the upper anteriors are also completely damaged. So what do we do is that this is an occlusal disease. It's not an yet another case wherein I just put root canals and crowns. None of the teeth were root canal treated. Please, that's another confusion what people do. So there's an occlusal disease. So I need to treat the occlusal disease, not the lost tooth structure. The lost tooth structure is because of the occlusal disease. So what? We try to rehabilitate the patient with what? Why this all happened is because of muscle force. So I need to tame the muscles down. So the first part is to deprogram the muscles, making the muscle understand this is not where what you should do something else. So bringing back the muscles and then able to relate the centric. It will take at least 3 to 4 weeks for me to record the centric. Only then I do a functional articulation and find out what's going on where. So now I tame the muscles to understand that this is where the joint has to be. I will bring the position of the teeth where you love to, because this is where they love to. They didn't like the position of the teeth, so they chopped off all the teeth. The muscle just chopped off. I don't like where you are, just get lost. So The patient cannot live with this. The patient has to have a functional occlusion. So I tell the muscles that this is where the teeth will come, which will also be in coordination with your muscular position. Once we find that, we have to rehabilitate the posterior. So what is the choice? Obviously ceramics, a softer ceramics. I love glass ceramics, and glass ceramics will be done for all this. We don't do tabletops here because all the cervical portion is gone. So full crowns. So all the posteriors, the 4+4, 8 had full ceramic crowns with Emax. Once that was done, the lower anterior tooth structure is very good. I can wind it up with composites. Those are my composites. So you understand, it's not you make a cup of coffee and pour that coffee to everybody comes to your house. You ask them at least, what do you want to drink? You want to drink something hot? You want to drink something cold? You want to have coffee? You want to have tea? You want to have cold coffee? You want cappuccino? So many varieties are there. You cannot have crowns everywhere crowns. You cannot have ceramics everywhere ceramics. The patient was okay with a smile and apparently it's okay, doc, I'm old enough, I'm not bothered. So I just left off the upper segment completely. So the lower posteriors were ceramic crowns, upper anterior was finished with composites. So I hope this case was able to give you a brief of what I was trying to explain to you, because it's very important that we restore it as a biologist and not as a technician. This will give us a beautiful success story for you to write, because ultimately everybody wants to practice responsible dentistry with predictable success. So I'll just like to wind up with one saying that life is not about always achieving goals. Everybody in this globe cannot be winners. There has to be losers. But the problem is not about losing the game, not playing the game at all. So let's play the game. Let's have a goal for quality dental practice, a successful dentistry. So no longer people blame the medical profession. Today, everybody tells that, oh my God, what you dentists do, just charge so much. Yes, I do charge, but I give you what you want. Let's change that in creating happy, beautiful, satisfied patients that come back to you and tell that my dentist, I love him. He's the best in the world. Let's change. Change can happen, not by a single person, but the entire community. That's my pledge here. Let's all together join hands and change what's happened to a better future. So any questions, I'm open to take up. And if you want any further communications with me, definitely you can go to my Instagram handle, message me there, or at drmohanb, where you can see some pictures or cases and some vital points about day-to-day dentistry. Definitely that will be helpful. Thank you, Dr. Shah, and thank you, Dr. Plexus, for giving me these opportunities. I'm always happy to take up any number of questions. Don't worry.
Thank you so much, sir. This was a very insightful as well as a very motivating lecture for all of us, I feel here. We do have a couple of questions for you.
Yeah.
So my first question is, what are some of the important considerations in defining vertical dimension in cases of congenital dental abnormalities?
So as I told you, the vertical dimension is already determined by the length of the masseter. So there are two things that can happen. One, that we have complete set of teeth and undergoes attrition, the bone will come along with that so that it gets compensated. Sometimes it cannot get compensated, the vertical collapses like that. In congenital missing teeth, like how we treat edentulous, right? Edentulous patient, we determine the vertical dimension, right? At a rest position, that is, we determine the muscular position. So when congenitally something is absent or something, we consider the patient as an edentulous patient, or try to capture the bite what the patient is having. For that, vertical, even before I decide the vertical, my centric has to be recorded. So the first point is to record the centric. The minute you record the centric and put it into a functional articulation, it will automatically give you a clarity of how the vertical dimension has to be handled. And my only request is that please don't arbitrarily tell that I'll do 2 mm for this patient, I'll be doing 3 mm. That is not the way it works.
Sure, sir. That brings me to my next question. So what are the key factors that influence tooth preparation?
Today, tooth preparation, we tell it's digitally guided and biologically oriented. So it's more biological. So we select materials. Probably today, every material just needs a 1 mm of clearance that is required, as minimal as possible. That gives space for a restorative material. That is one line which I could tell you, because if somebody is going to ask me, tell me the reductions of ceramic crown, that's absurd today. It varies from case to case. Within the mouth, it varies. Like I showed you the last case, the treatment plan is just not crowns for everything. Within individual tooth itself, it varies for me. So it is completely guided and biologically driven.
Thank you, sir. I think that was a wonderful answer. My third question is, what are some of the restorative concerns in treating trauma with from occlusion?
So trauma from occlusion, like you saw that case, if somebody could tell that trauma from occlusion and it is that's why it are treated, the material option depends on the bondability. So today it's called as bonded dentistry. So we classify bonded and cemented processes. As much as I can do bonded dentistry, I'm minimally conservative, but not at the cost of success. Where my tooth structure is so small and I can't tell that my bonding is going to work, I need to convert it into full coverage cemented processes. So the decision is whether you can bond it or not bond it. The minute I bond it, I have two options. One is composites and one is ceramics. So the longevity. Anteriors doesn't take up so much force. So anteriors, I don't mind putting composites. So when I'm doing a posterior rehabilitation, it takes me 8 months to 9 months to get the patient back to normal. See, I tell my patients, don't expect an overnight magic. See, did this happen in 1 year? It happened in years together. Then you can't expect a solution. You walk into me and next day you become moderate. That doesn't happen with me. I'm very clear about it. Everybody speaks the same language, has one vision and the same page. You spend 20 years doing all this, and I take 8 months to rehabilitate. So in that 8 months, if I'm doing a posterior composite, it wears away in 6 years. 6 years is like this. I don't want to go through my patient all over again another 6 years. I want to give them at least another 10 to 12 years span, which my ceramics can do. So all my posteriors, rehabs, I stick on to ceramics because the wear resistance is such that the patient can carry on with that for 12 to 15 years, which I myself have a follow-up of 15 years. Anteriors, the forces acting are very less. I can do away with composites, right? So the choice is again how you plan the treatment and that particular case.
My next question is, what happens to group function occlusion in cases of over eruption and unopposed posterior teeth?
This is one tricky question, and day to day we see people coming with one upper molar sticking there. In fact, sometimes it is on the lower ridge. Or the upper molar is on the upper ridge, and patient comes and suddenly realizes that I need teeth, doctor. Where is the space for the opposing tooth to do? You don't have space. That is one problem. And then the eccentric movement is completely gone. It's somewhere, what happens is playing of teeth. That's what we call that tooth coming. And to create space, the premolar sometimes move away and do that. There are so many things happening. Theoretically, you see orthodontics have to be done to move the teeth. But this is a very slow process. It takes years together, a decade to happen to all this. So this is not a case of attrition. So the bone is going to move along with that. So it is like what we tell is that design, plan, and then execute. None of us pack our bags, go to airport and decide where we want to go. Do we do that?
No.
Your destination is finally decided. So where exactly they will flow, where your tooth will flow, what you want, you establish that first, and how you want is you establish second. So I want my posterior teeth to come back and this to go up. So I need space. I'm going to put an implant. I'm going to do a partial denture. I'm least bothered about that, but I need teeth there. How will this upper tooth go? Is amount of tooth structure that is required for this space. Either you do a conversion crown, or if warranted, we do a root canal therapy and do a conversion crown. Worst case, worst, I would not want to tell that, but sometimes there are cases we need to extract because the bone is very much there. So it is a tricky situation wherein you design and then you plan. Like I tell you in a very, very jovial way, when we plan for vacation, a family, everybody has one place to go. But finally, we make one decision, which is everybody's happy, right?
Correct. Yeah.
That's exactly plays a role into my day-to-day dentistry. My patient has certain set of ideas. I have certain set of ideas. Every specialist has a certain set of ideas. All of us sit down together, including the patient. That's very important for me. My patient has to see what I'm seeing. If a patient doesn't see what I'm seeing, is not going to accept your treatment at all. Please believe me, this is a mantra for us. My patient sees on a laptop what exactly we are discussing, then he's in the same page. Not only specialist, including the patient, is a journey for us to travel with. We all collectively make a decision. Patient is really happy.
I think that's a very valid point. Brings me to my last question. Could you elaborate a bit on the adapted centric posture?
Yeah. So in a room, if 100 people are there, I spoke about centric and maximum intercuspation, right? Probably one person will have the centric and the maximum in the same place. Otherwise, none of us will have the centric and the maximum matching. So first is centric and maximum just matching like that. Maybe 1%, 2%. Then somehow we get adapted. The joint gets adapted to the position of the teeth. It doesn't show up. So people who don't show up and still living in that mismatch is called adapted centric. When people show up, they have lost the adapted centric and the occlusal diseases set in. So here is a lucky group. They don't show up with any complication of orofacial pain, muscle pain, attrition, anything, but still the centric and maximum doesn't match. It's a very small limit when you can move your joints. So that is adapted centric. I think 50% of us live in that adapted centric.
Sure. I think this brings me to my end of my program. I do not have any more questions for you, but I am sure that if we receive any more questions from our audience,
sure, I'll be more than happy. I hope
yeah.
I did justice to the time
Definitely,
what you gave, and I tried to do my best. I hope that was okay with everybody.
Yes, yes. So thank you so much, Dr. Mohan, for coming on DocPlex and speaking to us and addressing our audience on such an interesting note. I'm sure even the audience was able to learn a lot out of it. Also, dear audience, do we have any more questions? Please share them on the comment section below, and we will get back to you with the answers. Until we meet again, please take care and have a great evening ahead. So thank you so much.
Good evening to all of you. Thank you so much. Thank you. Bye-bye.